Good morning. Welcome to Grand Rounds at the UCSF Osher Center for Integrative Health. My name is Shelley Adler, and I have the pleasure of serving as the director of the Osher Center. And today I am delighted to formally introduce, although I'm sure all of you are aware of, Dr. Richard Nahin. Dr. Nahin earned his PhD in psychology and neuroscience from UCLA. As well as a master's in public health and epidemiology from the Uniformed Services University of the Health Sciences. He serves as chief of the Epidemiology Program at the National Center for Complementary and Integrative Health in the Division of Intramural Research. Dr. Nahin oversees research on the prevalence, costs, and usage of complementary health approaches in the United States, managing major national health surveys, which many of us rely on heavily in our work. Dr. Nahin began his career at the National Institutes of Health as a postdoctoral research fellow, and then within a few years advanced to senior staff. He then transitioned to become a scientific review administrator at the National Center for Research Resources before joining NCCIH. Over the years, he's held various key positions, including director of the Division of Extramural Research and Training and senior advisor for scientific coordination and outreach. He received 3 NIH Directors Awards for his significant contributions to NIH. After Dr. Nahin's presentation, we'll have about 10 or 15 minutes for discussion. So please feel free to submit your questions to me by way of the chat feature, and you can do that at any time during the presentation so you don't forget your questions. And during the discussion, you can also come on video and or audio and pose questions directly to Dr. Nahin. Finally, I want to thank our terrific Grand Rounds Planning Committee, Drs. Patty Moran and Selena Chan, as well as Jen Shea, Yvette Coulter, and Julia Burns. And now, please join me in virtually welcoming Dr. Nahin.
Hello, everyone. Let me just share my slides here. Okay, so hopefully you can see a list of people's names now.
We do.
Okay, so before I really begin, I wanted to acknowledge the many collaborators I've had over the years. Many of them still active, some of them retired. And I want to do a shout out. Shout out to 3 in particular. Patricia Barnes, who's recently retired from the National Center for Health Statistics, Morgan Jackson, who's retired from NCCIH, and Barbara Stutzman, who's still here with me after 20 long years. These 3 were with me at the very beginning of the program, and it was their dedication in these early years that made the program any success it's had. So today, again, my title of my talk is Survey Perspectives of Complementary Health Approaches, and I'm going to organize these by the who, what, when, where, and why of the use of these approaches. So almost all the data I'm going to present today is from the National Health Interview Survey, or NHIS, that I'll usually call it. NHIS is run and managed by the National Center for Health Statistics, which is part of the CDC. What I posted here is language actually from the NCHS website describing the NIH survey. It says it's the U.S. government's primary annual national survey to monitor the nation's health, and as such is the primary source of outcome measures for the U.S. Department of Health and Human Services Healthy People Initiative. So maybe not everyone on the call knows what Healthy People is, but since the year 2000, it's been the metrics in which the U.S. government, no matter who's in office, monitors the health of the nation. And so every year, NCHS, in close collaboration with the Census Bureau, will randomly choose a nationally representative sample of approximately 30,000 adults, and that's with 2,000 or 3,000 up or below, and 100,000 children annually. In most cases, the surveys are still done in person, which is rare. But since COVID, it's increasingly done by telephone. So many of you probably know that every 5 years, beginning in 2000, NCCIH has added questions on the prevalence and reasons for use of complementary health approaches. And this, again, is going to be my talk. But there have been some misunderstandings over the years on why we add these questions. We're not adding them for research reasons, though, of course, many people like myself use them for research purposes. We're actually adding them to the survey for strategic planning purposes. All the 27 institutes and centers that make up the NIH have strategic plans. And approximately every 5 years, they're reevaluated and updated to meet growing needs. And so the data from the NHIS that we add, the questions we add, are really the backbone of the strategic planning process. Now, I was asked today to describe the methods we use to develop the surveys, but that's a talk in of itself. So I can't do that here. I'm just going to refer you to this paper. My longtime collaborator, Barbara Stussman, was first author. And in this paper, which was published like 12 years ago, I think, we in great detail described the processes we use both to develop the surveys and to validate them. So I would suggest you try to find this paper. So over the years, and we just finished our fifth round in 2022, we've added many different complementary approaches to our surveys. Some of them, but not all of them, are shown here. And in fact, we've never had a survey where we asked about every possible approach that's in our portfolio. Now, the reasons we pick specific approaches for specific years is based on two things. One, as I already said, strategic planning. In some years, we're interested in some interventions, but not others. And then also, importantly, it depends on how much time the National Center for Health Statistics will give us on the survey, on the NHIS. Every federal agency is allowed to add questions to NHIS, and certainly NIH, with its 27 institutes and centers, contributes a lot of questions every year, as other portions of the CDC, the Veterans Administration, HRQ, on and on. And so there's competition for space. The more people who want to get it in a given year, the less space I will get. In addition, over time, NCCIH has intentionally reduced the overall length of the survey. Back in 2012, which was the largest year, I think, for the survey, it took about 25 minutes for a person to complete the survey. This has been cut down. I should say, that's right. But now the average time is much less. So for instance, our surveys, and I was talking about the amount of time for our survey took about 20 minutes in 2012. In 2022, the most recent year, it took 5 minutes. That's how much time we were given. So we cut down the questions substantially. So let's begin with who, what, when, where, or why. We'll start with the why views. So every year we ask about, if someone says they used any complementary approach, we ask them about the types of health conditions or problems they might use the approach for. So for instance, this is data from 2007, and you can see on the bottom of the slide, there's a whole bunch of different health conditions. Now, again, based on the questions we add and the questions that other people at NIH add or across the federal government, this list changes pretty much every year. And this particular, this is the list. And what I'm going to show here is the number of adults in millions who use some complementary health approach, anything from that list I showed you for the particular problem. For instance, in 2007, there were about 11 million people who said they used a complementary approach for their back pain. In the same year, about 5.5 million said they used some complementary approach for their neck pain. And in fact, looking at the rest of the data, the top 6 reasons people use these approaches are for pain conditions. For instance, here, back pain, neck pain, joint pain, other musculoskeletal conditions, any type of arthritis, headaches, including migraines. And if you look at the next 3 conditions, these are all mental health conditions. You have stress, anxiety, depression, and insomnia or sleep. Now, from the data from our very first survey in 2002, when we were first looking at it, we were surprised how little complementary health approaches are used for the chronic conditions in the United States that are responsible for so much mortality and morbidity. For instance, in this slide, the far right-hand side, see very few people are using complementary approaches for hypertension, high cholesterol, and diabetes. And in fact, if I were to continue this slide to the right, we would see even data for coronary heart disease, cancer, asthma, and COPD at even lower levels. And so again, even though the specific health questions asked in the NHIS varies year to year, we still see this pattern across all the years we've looked at it. So that led us to conclude that pain is a primary health reason, if not the primary health reason people use complementary approaches. But of course, people use complementary approaches for a variety of different reasons. I know you all know that already. And so in different years of the survey, asked about different approaches. So for instance, this is data from 2012. You can see in this slide, we're asking about whether people use the approach for any type of health problem, so not individual problems here, but combining them all, as well as for general wellness or disease prevention. And these two topics, I think, are in every year. No matter how much space we get, we always fit these two questions in. And here I'm showing data for acupuncture, naturopathy, and yoga. And that was just because I couldn't fit any more on the slide. So for instance, for acupuncture, 87.5% of people who used acupuncture are using it for a specific health problem. For naturopathy, it's still pretty high, 73%. But for yoga, it's quite low. Only 17% of people using yoga saying they're using it for health condition. And so the data I'm going to show you for general wellness is pretty much mirror image of this. Here for acupuncture, we see only about 36% of people who use acupuncture are using it for general wellness versus 78.6 for naturopathy and 79.9% for yoga. So you can see that acupuncture and yoga are used very differently. Now, naturopathy is high in the slide, and actually compared to all the other health conditions, all the other approaches we look at, it's the only one that's high in both general wellness and treatment. And we've hypothesized, though we can't prove it, that this has a lot to do with how naturopathic physicians are trained, and that they use a whole person health approach, which would talk about both treatment and maintaining health with wellness. So in 2012, we asked about other reasons people might use these approaches. These are here. You can see that here I'm listing whether they use these approaches for stress reduction, to improve energy, to improve immune function. In this case, I'm showing data for natural product supplements, spinal manipulation, and yoga. So for instance, here's the data for natural products. You see, people who use natural products, 20% are saying they use it for stress reduction, 31% to improve energy, and 42% to improve immune function. We see the exact opposite pattern for spinal manipulation. It's not 40% to reduce stress, 16% to improve energy, and only 11% to improve immune function. Now, yoga has the same pattern as spinal manipulation, but at much higher rates. You can see 86% of people who use yoga say they're using it for stress reduction, for instance. So a conclusion of these last few slides is, of course, that people use complementary approaches for a variety of different reasons. And there's many other reasons too that I just can't show in today's talk. In addition, that these approaches tend to be used for specific approach reasons, such as acupuncture versus yoga or chiropractic, spinal manipulation versus yoga, used very, very differently. But there are actually other ways you can look at the why of use. Now, if you look at the health economics literature, you'll often see that health economists will equate use of some health approach, whether it's conventional or complementary, as an indication of value. Okay, an example of this is the COVID vaccine. If you're a person who rigorously gets the updated vaccines as they come out every year, you probably think, for some reason, you probably think that the vaccine is going to help you prevent getting the disease, COVID, or reduce the severity of the disease if you do get COVID. So you would give the vaccine sort of a high value. But there are then, of course, those people who don't get vaccine. And there's probably a whole different populations within that group. But one population are those who simply say, well, I don't get sick. I'm young, I'm healthy, I never get sick. I don't see any reason why I should get the vaccine. And those folks would maybe give a little negative value to the vaccine or maybe a neutral value because they don't really know if they need it or not. But then there are those who say, I'm not going to get the vaccine. Not only does it not work, but it's dangerous. It could harm me. So these people would give the vaccine a very negative value. And so there are a lot of different ways that health economists will try to establish this value. One of the more common ones I've seen in the journals I look at least for health economics, are to combine the perceived effectiveness of an intervention, again, complementary or conventional, and the amount of money that a person is willing to spend on the intervention, putting those two together in the same study, the same cohort. Now, while the NHIS actually does collect information on both of these, unfortunately, it never does that in the same year. So I want to present data on each of these separately. And I'll start with the perceived effectiveness. So in the 2019 NHIS, if you reported having any type of pain in the last 3 months, you were asked if you used any of the approaches on the screen. Back pain education programs, chiropractic care, cognitive behavioral therapy, group therapy, massage therapy, meditation, opiates, physical therapy, occupational therapy, yoga, or other, with the other, of course, being anything not on the slide. So that includes a large range of both conventional and complementary approaches. So if you say you used any of these or all of them even, you then get this next question, which is asked over the past 3 months, how effective do you think you were in managing your pain? Very effective, somewhat effective, only a little effective, or not effective at all. So I'll be showing you these data for 2019. So in 2019, the survey had 32,000 adults. That's a pretty good sample size for NHIS. And using the Census Bureau sampling weights, which you should use if you're using these data, these 32,000 individuals would represent 250 million adults. So in this population, in this year, 37% said they had back pain in the previous 3 months. Now, of the health conditions asked in this particular year, again, the health conditions asked varies year to year, back pain was the most prevalent condition of the pain conditions. So we decided to just look at these. And this study is being done with my very frequent collaborator, Debbie Feldman at the University of Montreal. So what I'm going to show you on this side is the number of treatments used by those reporting back pain. And on the x-axis, you see I'm dividing number of treatments into 0 treatments, 1 treatment, 2 treatment, or 3+ treatments. So here's the data. So when Debbie and I saw this, we were really surprised at the number of people who were not getting any treatments. Again, the others, any treatment for their back pain. And so in fact, we were so interested in this that we quickly wrote an article that was published last May, describing this population in great detail. But for today, the talk today, we want to look at efficacy. We were very interested in this group, individuals who only use 1 treatment for their back pain. So if you've read any best practice guidelines for back pain management in the last 10 years, you'll either see them specifically say that the gold standard is some kind of multimodal, multidisciplinary pain management, or they'll imply it, but they won't use those words, but they'll imply it some other way. So we were interested in this group because these are people who are getting some treatment, so they're able to get treatment, and yet they're not getting a gold standard treatment. So we were wondering what they were actually using and how effective this treatment was. So in this slide, for people who had back pain who only used 1 treatment, I'm showing the prevalence of use of all the different approaches on the x-axis. And so for instance here, 50% of people who had back pain and used a solo treatment said they were using other. Again, others high because there's a lot of things in the other group. Big drop off to massage therapy, just a little bit more than 10%. Opiate use, about 9%. And here's the rest of the data. So the farther the right to go, the less prevalence. And you notice for the let's more go to the left, the lower the prevalence. So the 3 conditions on the far left, cognitive therapy, group therapy, and pain management. So few people use these interventions for back pain that we didn't have enough sample in each of these groups to look at the efficacy. So the efficacy data is just going to be on the remaining types of interventions. And that's shown here. Again, the interventions are on the x-axis, and on the y-axis, we're looking at people who used these approaches and said they were at least very effective. So this is high effectiveness. So here's some data. You see people who used opiates for their back pain, 30.7% said that this opiate use was very effective for pain management. Physical therapy, occupational therapy, a little bit higher. Massage therapy, a little bit higher still. So here's all the data. See a range from 30.7% for opiate use to 47.6% for chiropractic use. It's a very good range, about 17 points in between the lowest and the highest. And in fact, in the preliminary analysis, we compared all the other groups to opiate use. And it turns out that people who used only massage therapy, only meditation, only chiropractic reported much more efficacy in their pain management than those who used only opiates. We think this is very interesting data, and we're currently doing all these different subgroup analyses and regression modeling and stuff. But Debbie and I have to constantly remind ourselves that these are not data from randomized controlled trials. These are data that are self-reported by individuals who either currently using the approach or used it within the last 3 months. That's the time frame for the question, did you use this approach, any of these approaches in the last 3 months? So that creates a situation of different types of bias. The primary bias is self-selection bias. Unlike a clinical trial where you're randomly to assign groups, here you, for whatever reason, are deciding to use an approach. Again, some of the approaches like meditation and yoga, you don't have to see a healthcare provider for those kind of approaches. So the self-selection bias has a lot of issues with it. There's an expectation that if you're decided I'm going to use an approach, I'm going to use approach X for my back pain, there's an expectation that you think, for whatever reason, that it's going to help you. And so this expectation bias can lead to two things. It can produce an enhanced placebo effect, and it can cause a cognitive dissonance when you're taking the survey, so that you want to end up rating the effectiveness of a given intervention higher than you would probably in a randomized controlled blinded trial. There's also the issue if you're self-selecting to use something for whatever reason, you say, I'm going to decide to use intervention X because my family, my father used it and he thought it was great. My sister, I read a controlled trial report and it said it was great. On the same way, you're also choosing what not to use. So for instance, maybe your grandmother didn't like projects, so you don't want to use it, or you read a clinical trial showing something doesn't work, or you yourself used it previously. It's not uncommon for people with back pain to get recurring back pain. I certainly do. And so if I were to use an intervention 2 years ago and it didn't work, it's unlikely that I would use it for my back pain this year. This means that the data we're looking at are underrepresenting approaches that were ineffective in the past. Okay, I'll say it again. We're underrepresenting approaches that are effective in the past because people aren't reporting on them because they're no longer using them. So Debbie and I understand these data. We're still pursuing the project because we think it's so interesting. And in our discussion, we'll just try to lay out all these issues and say we understand them. And this is what we think that the bias is going to be doing to our evaluation. So let's turn now to the willingness to spend. This could be a more objective measure than self-report of pain effectiveness. I say could be because if you look at the health economics literature, they often ask questions like, how much would you pay if I could give you one pill today and you would never get cancer? Or how much would you pay if I gave you one pill today and you never get Alzheimer's disease? Those are so speculative. I don't know how to process them myself. But if you look at actually how much is spent in a given year by a given person, then it is very objective. And in particular, we want to look at out-of-pocket costs because in terms of health economics, if it's only costs to the individual that show value, if everything is reimbursed, then there's no value. It's sort of cost neutral. So we're going to begin by looking at total healthcare spending for back pain in 2007. You can see on this slide, it's $39.7 billion in 2007. Obviously, if we looked at 2022 dollars, this would be much, much higher, probably double. So I'm going to break it out into this 39.7 billion to constituent parts. You can see of this, 63.7% is spent for conventional care reimbursed, and 1.3% is spent for chiropractic care reimbursed. So again, reimbursed care is cost neutral, has no value. And while I'm sure there are other approaches that had reimbursed costs in 2007, the national data sets I was using in that year only had chiropractic care. So in terms of the other dollars, 13% was spent on conventional care out of pocket, and 21.9% was spent on complementary care out of pocket. So it's clear that complementary medicine is used more. In fact, the dollars spent by people on complementary care for back pain was 67% higher than for conventional care. But let's move from just looking at back pain, which is important, but certainly a small part of total healthcare. Let's expand to look at all healthcare costs, which in 2012 was $2.82 trillion. It's trillion with a T. And of course, that's 2012 data, 2022, who knows how much it would be. So again, we're going to break these into constituent parts. So we can see the vast majority of this $2.85 billion is spent on reimbursed care for both conventional and chiropractic that were captured in this year. We see 12.5% was spent on conventional care out of pocket and 1.1% was spent on complementary care out of pocket. Now, some of you who are watching this talk may look at the 1.1% and say, that's nothing. 1% is nothing. It's like only 1 cent on every dollar. But when I look at it, I say 1.1%, that's a huge amount of money. That's 1 cent out of every dollar. And I'll try to explain my enthusiasm in the next few slides. So what we're going to do now is concentrate just on the out-of-pocket cost, because then in terms of health economics, that's the important cost. So out-of-pocket costs for total health care in 2012 was $386.9 billion. And so this is how it breaks out. 92% of this $386 billion was spent on conventional care and only 7.8% on complementary care. So again, some of you are looking at the slide and say, well, 7.8% is better than 1%, but it's still not a very big piece of the pie. And my collaborators and I would agree with you. It's not a very big piece of the pie. But you have to also remember that the approaches that make up complementary medicine, complementary health approaches, are very different than the approaches that make up conventional care. For instance, one of the most invasive types of complementary approaches used in the United States is acupuncture, where you're getting needling. If you look at invasive procedures in conventional care, we're talking about open heart surgery or colonoscopies. And so the question is, are we really willing to compare acupuncture to these invasive medical approaches? We would say no. We would say what you want to do is compare like to like. So we're going to break these pieces of pies into their even smaller pieces. So we see that, for instance, 2012, the US public spent $14.8 billion on complementary approaches out of pocket. We see that they spent $14.7 billion on provider care, complementary providers. They spent only $0.07 billion for other complementary approaches, but this is things like meditation, Tai Chi, Qigong, guided imagery that might have some initial startup cost. You take a course, you take some classes, you buy some yoga appropriate clothes or a mat, but then there's no long-term cost. We can see that office-based physician care is $51.6 billion. Prescription drug use is $45.1 billion. Over-the-counter drugs are $28.9 billion, and all their costs are conventional costs. This is primarily driven by hospitalization, ER visits, and invasive outpatient procedures, but also includes costs to allied health providers, nurses, physical therapists, occupational therapists, and the like. So of these different pieces of the pie, the two that we thought were most similar were natural product supplements and OTC drugs. Now, why do we think that? It's for two reasons: access and availability. And by access, I mean that there's no gatekeeper for these products. You don't need to see any kind of healthcare provider or see anyone if you decide to use them for whatever reason. You simply purchase them. And in terms of purchasing, you can purchase them everywhere. They're available everywhere nowadays. Going back to when I first started at NCCIH back in 1996, when I was still the Office of Alternative Medicine, even back then, every grocery store in my neighborhood, every drugstore in my neighborhood had rows and rows of these products, often on the same shelf. So even though these products are manufactured very differently, marketed very differently, and importantly regulated very differently, we think, me and my investigators think, the general public tends to treat them as the same. So let's compare these two products only. So we're gonna, in the next slide here, we're showing the total cost in 2012 on these products was $43.7 billion. Here's the breakout: 66% for over-the-counter drugs, 33.9% for natural product supplements. So now some of you are thinking, well, a third, that's a third of the pie. That's a pretty good slice of pie. But let's look at these data even closer. So as it turns out, and maybe you already know, OTC drugs are used a lot more by the US public than natural product supplements. In 2012, there were 185 million adults who purchased an OTC drug versus 40.5 million who purchased a natural product supplements. So that's 4 times more people bought OTC drugs. So if we take these data and use them as a denominator, we can look at the average per person cost for individuals who buy each of these products, which is here. So in 2012, the average cost for a person who bought natural products over the course of the year was $365 per person versus $155 per person for those who use OTC products over the course of the year. So that's double. So you can see here that this clearly shows that people are willing to spend a lot on complementary health approaches, and in many cases, even more than for conventional care. So of course, that's the willingness to spend data. If we had done this right, if we had the right data, we would want to do what a health economist did: combine the perceived effectiveness data with the willingness to spend data, and then we would have been able to answer questions like this: is there an association between self-reported efficacy with per-person expenditures on complementary health approaches? So this has been my white whale for the last 10 years. I've been looking for data that would allow me to do this. I finally figured out it's never going to be available. So we're currently developing a protocol here at NIH that will allow us to, at least in a small sample, not anywhere like an NIH study, but a more small sample, we figure about 400 people, to try to collect these data and really do the study properly. So we're going to move on now to the when of use. And when I say when, I'm really talking about, are there changes over time in the use of these approaches? So what I'm going to show you in the next slide is a bunch of surveys that collected national prevalence data on use of any complementary approach in adults between 1990 and 2012. Most of these are in-person surveys, and some of them are telephone surveys. There's no by mail surveys here. So here's the data. You can see that most of these prevalence fall between about 30% and 43%. Some variation, but that seems to be the range, especially between 30 and 40%. But there are outliers. You can see there's some low outliers here. The one that only used 4 complementary approaches used, if I remember right, chiropractic, massage, acupuncture, and relaxation techniques. And the one that only looked at practitioner approaches had similar groups: acupuncturists, massage therapists, chiropractors, homeopaths, and traditional healers, which are defined in the survey as anything from curandero to Native American healers to shamans, a whole list of practitioner types. But the fact is, they're only both surveys are only asking about a limited number of approaches. And as you might think, the more approaches you have in a survey, the higher the overall prevalence will be. And then there are these high outliers. These high outliers either included prayer in the definition of complementary health approach or vitamins and minerals. Now, since the time David Eisenberg published his seminal 1991 New England Journal article looking at the first national data on these approaches, and that's the very far left-hand square on this slide, people have had occasional discussions in the literature about whether vitamins and minerals should be in the use of complementary health approaches. I'm not arguing that at all here. I'm just trying to say is that the choice of approaches change the prevalence. And to make these data even more complicated, investigators have used the same data sets, but used different definitions of complementary health approaches to come up with different prevalence rates. We're hearing examples from 3 years that NHIS survey produced very different prevalence rates on how these specific authors defined complementary health approaches. And for that reason, my overall take-home message is, yes, it seems to be fairly flat in use, but I'll show some data suggesting maybe not, the real take-home message from that slide is that you should never take reported overall CHA use prevalence at face value. You have to find out how it's being defined, because that's really going to tell you, how comprehensive the look is. So in our most recent paper, which was published last January, we looked at just individual health approaches in terms of trends. You can see here we looked at acupuncture, chiropractic, guided imagery, and/or progressive muscle relaxation, because they were sort of small individually, massage therapy, meditation, naturopathy, and yoga. And we looked at 3 years of the NHIS, the earliest year, 2002, 2012, and then 2022, the most recent year. So for instance, here's the data for acupuncture. It went from about 1% in 2002 to 1.5% in 2012 to about 0.5% in 2000. No, 1%, that's right. 1% in 2002 to 1.5 in 2012 to 2.2% in 2022. A very substantial increase over time. Here's the data for chiropractor. It went from about 7.5% in 2002 to about 11% in 2022. Now, you notice I'm not showing the data for the 2012 data, and actually instead there's letters that say NA, which stands for not applicable. That's because for strategic planning purposes, in that year, we weren't interested in looking at overall use of chiropractic care. We were looking at a specific intervention, spinal manipulation, which is not the same. So we didn't want to include that on this slide. So here's the rest of the data. So you can see for every approach, and these are very different types of approaches, we saw substantial increases over time. We saw a 4-fold increase for naturopathy, a 3-fold increase for yoga, more than 2-fold increases for both meditation and acupuncture. So we're following up these data by looking at the who and where of this use. Specifically, we're asking which specific demographic groups are exhibiting these increased uses over time. Is it one specific demographic group, or are we seeing it across demographic groups? And I'm very pleased that I'm doing this study in collaboration with members of the UCSF OSHR team, Dorothy Chu and Maria Chow. And it's very interesting data. I'm going to show you just a limited piece of this data, which is quite large. So here today, I'm going to show you the impact of sex, age, education, and region of country on the use of chiropractic care. So here we're going to start with age, and for this particular slide, I've divided age into 3 categories: 18 to 44, 45 to 64, and 65 plus. And I'm showing the data for both 2002 and 2022. So here's the data for 2002. You can see that the 65-year-olds are substantially less likely to use chiropractic care than the younger age groups, but there's no difference between those 2 younger age groups. They're about the same. Here's the data for 22. We see that, again, the older age group is least likely to use chiropractic care. There's still no difference between the younger age groups. But in terms of the trends over time, we see that they all had similar rates. So even though older adults are using chiropractic in both years at lower rates than the other age groups, they saw an equivalent increase over time, from a 44% increase versus a 54% for the 18 to 44% group. Not really different in their trends. So moving on to education, in this slide, I've divided education into 3 groups: those who didn't graduate high school, and surprisingly, still 10% of the U.S. population never graduates from high school; those who graduated high school or have an equivalent, but never graduated from a 4-year college; and then people who graduated from a 4-year college. So here's the data for 2002. So what you can see is that those who never graduated high school were much less likely to use chiropractic care than the high school or college group, and there was no difference between the high school and college group. In 22, we still see that the less than high school group is substantially less likely to use chiropractic care. But in 2022, we now see that those who graduated college are substantially more likely to use chiropractic care than the high school group. And the reason we're seeing this is because they saw a substantially higher rate of increase over time. You can see for the high school group and the less than high school group, there was about a 30% increase over time for chiropractic use. There was a 60% increase for the college group. Going on to sex, we see that both years, females are much more likely to use chiropractic care than males, but the difference in 2022 is higher, as a bigger difference between males and females. And that again is because in females, we saw a slightly higher rate of increase versus males, causing a greater separation. And then finally, looking at region of use, we use the census regions, Northeast, Midwest, South, and West. So we can see here, I'll walk through because there's a lot of pieces. We can see the South with consistently less use of chiropractic care than any other regions, Northeast, Midwest, or West. In addition, the Midwest had higher use than the Northeast, but the West was not different than either the Northeast or the Midwest. Here's the data for 22. We now see that the Midwest is higher than all the different groups. It's higher than Northeast, South, and West. And we still see a difference between the South and the West, but the difference between the South and the Northeast disappeared. And the reason the difference between the South and Northeast disappeared was because there's a big difference in the percent increase for these groups over time. You can see that the Northeast saw about a 30%, a 29 to 30% increase over time, while the South saw a 75% increase over time. And that led to the closing of the difference between them that we saw in 2002. So I've quickly gone through some of the characteristics of subpopulations that use chiropractic care, but we have to remember that the demographic variables I just showed you are often related. I mean, there's years and years of census data showing that education and related is very correlated. Year after year, individuals in the South, as a unit, the South has a much lower higher education attainment, less likely to finish college, less likely to have a high school degree, to do other regions. In addition, there's a strong association between education and sex. For instance, in the 2002 NIH data in that year, if you looked at census data, you would find that males were substantially more likely to have a college degree than females in 2002. But by 2022, females are more likely to have a college education than male. So all these things are related. So what we really want to do is to somehow isolate the impact of each demographic use independently of the other and look at CHA use. There's probably a lot of different approaches you can do. The most common is using some kind of regression modeling. In this case, because the outcome variable was chiropractic use, yes, no, that's a dichotomous variable. And for dichotomous variables, you must use logistic regression. So I'm going to be showing you data from a multivariable logistic regression model. These are the variables in the model: age, sex, education, region of country, which you've seen prevalence data for, and then race and Hispanic heritage, which you have not seen any data on yet. And then to try to adjust or control for underlying health status of these individuals, I also included whether the people had arthritis in the last year, diabetes in the last year, hypertension in the last year, and depression in the last year. So these are not like these early data where I showed you where we're looking at CHA use for these regions. These are just whether people have the conditions or not. So in this slide, I'll show you the data. You can see all the demographic data is on the x-axis. And what I'm showing you here is the reference groups. For instance, age, the reference group is the youngest age group. For sex, the reference group is the females. For education, the reference group is those with less than high school education. And, and since this is logistic regression data, the outcome of a logistic regression is an odds ratio. And if the reference group is 1, which is by definition, then odds ratio of another category that's greater than 1 increase odds of use, while odds ratio less than 1 would indicate decreased odds of use. Now, since repeatedly saying increased odds of use and decreased odds of use is a mouthful, and I would no doubt fumble it after a time, I decided to say more and less likely a colloquial use of logistic regression. So for instance, for age, the reference group is 1844, has an odds ratio of 1. We see for that 45 to 64 group, it's slightly less likely to use chiropractic care, but because those lines going up and down from the circle, those are 95% confidence intervals. If the confidence interval for either side crosses 1, it's not significant. But here's the data for this 65-year-old group. About 40% less likely to use chiropractic than the reference group. And again, this is controlling for all of the other variables. So these are people, and so individuals 65 and older are more likely to use chiropractic care, even after adjusting for sex, age, region, race, ethnicity, underlying health conditions. For males and females, we see that males are substantially less likely. Again, confidence intervals on there on the males are very small, but they are there, and then they're both below 1, so it's significant. In terms of college education, we see that those who have a high school degree and those who have a college degree are both much more likely to use chiropractic care than the less than high school group. The confidence intervals are large on both these data points, but still they're all the way above 1, so it's significant. In terms of the South is and Northeast, Midwest, and West. So you can see, as we saw in the 2022 data, and these are 2022 regression modeling, there was no difference between the South and the Northeast, and the Midwest is highest, and the West was high, but not as high as the Northwest. In terms of race, and this is a new variable I haven't shown you, people who self-reported as Asian or Black are substantially less likely to use chiropractic care in the regression model, about 50% less likely. Those who self-reported as Native American and other, which are those who are not Native American, Black, Asian, or white, they were also both less than 1 in terms of the odds ratio, but again, the confidence intervals are crossing, so they're not statistically different. Non-Hispanics who are substantially more likely than Hispanics to use chiropractic care. Individuals who self-identify with arthritis were more likely to use chiropractic care, but those who had hypertension, diabetes, and depression were equally likely, whether or not they had these approaches. So I've quickly gone through the who, what, when, where, why of use of complementary health approaches. I realized I went through some of this fast. I left out a lot of detail. I was trying to compress 25 years of work into 45 minutes of time. Hopefully we have time with the Q's and A's to address any issues you might have. But before I got to the Q's and A's, I just wanted to show you this slide. So I finally have been able to grow my program over the next 3 years. I'll probably triple the number of staff I have if our budgets hold. So I'm currently I'm currently advertising right now for 2 research fellows. Don't be fooled by the word fellow in the title. These are equivalent to a research assistant professors on an academic level. These people will be independent investigators. They'd, of course, collaborate with me and my other folks on the project, but they'd be expected to develop their own line of research that fall within the NCCIH strategic plan, to be able to get their own postdocs and pre-docs, graduate students. I realize this ends in 2000. I mean, the vacancy announcement ends in 2002. So hopefully, if you've already seen this and you're interested to apply, if you haven't seen it, there's still time. The ad actually says you're supposed to submit letters of support with the application, but if you at least submit the list of people who you're going to get letters from support of and submit it, we'll accept the application. We won't review it until we finally get the letters, but at least we know that you're trying. So with that, I will go to questions and answers. And I'm not sure how we're going to do this. Are people going to raise their hand, or we're going to open up the mic? I don't know how you want to do that.
You'll go in, Shelley.
Shall?
It's me. I'm just Shelley's going to enter in a moment and moderate the Q&A. So just be one moment.
Okay.
Hi, thank you so much. Absolutely fantastic and fascinating presentation. And apologies for the glitch there. We have a exciting new webinar features, which I'm still learning how to use. And let's move to the Q&A, as you said. I want to invite anyone who would like to ask a question live to come on audio to do that. We won't be doing this through video, but we can do it through audio. And let me go to some of the Q&A questions that have already been submitted. One of these has to do with reimbursement and very, very low reimbursement in some of the early surveys, and whether you're able to track use in terms of FSA and HSA, because a lot of complementary approaches, including acupressure mats, for example, step counters used for different things, are being reimbursed that way. Is that something that is able to be tracked?
Theoretically, I mean, the data, only data we've collected ourselves on the cost of complementary health approaches was in 2012. And it took about 150 questions to collect the cost data on the approaches, regardless of the rest of the survey. We're not ever going to be given that many questions again in HIS. It's quite clear. The survey itself has been, it's only about 1/3, the total survey any given year is about 1/3 what it used to be. And again, I was talking about the competition for questions. So for instance, in 2022, I think we were able to fit 25 questions in. It's never going to, I can't imagine it ever getting to the hundreds again like it was in 2012. Now, having said that, one way to get these data might be through claims data. We've just begun using claims data, not so much for complementary health approaches specifically, but looking at pain management. And we had a paper that I believe just came out in the Journal of Pain this week. Michelle Baum from the CDC was the primary investigator. And in that paper, we're talking about reimbursed care because it's Medicare, it's either commercial insurance companies versus Medicaid insurance companies. And so what we're really talking about in that paper is whether best practice guidelines are being used, which would include different kinds of complementary approaches and allied healthcare providers like PT. So if we wanted to, we could have looked at the actual costs. We didn't, because we were looking at prevalence data mostly.
Yeah.
But the claims data can be used for costs, but just understanding that it's not nationally represented.
Yeah. Okay, thank you. Another question has to do with survey approaches and if there is a trend regarding phone versus in-person administration of the survey and what the impacts might be.
I will say that National Center for Health Statistics would much rather do in person than phone, but especially since COVID, people don't want to do in person. So I think in 2022, it was probably 2/3 in person and 1/3 telephone, maybe. NCCIH does validation studies all the time. And as far as they can tell, there's no difference in their surveys on the types of responses. They particularly look at whether people are skipping questions or refusing to answer specific questions. And on those kind of metrics, there's no difference.
Yeah, it's such a significant change. We've got quite a few questions. I'm trying to see if I can group some of these. One, you spoke about demographics. If you could talk a bit more about the languages the surveys are offered in and what you think the impact is there in terms of findings.
Well, NHIS is incredibly unique. In terms of Spanish, it is translated Spanish, it's back translated, then back translated again. So they do a lot, they have panels that review the questions in Spanish to make sure the language is correct. And in addition, the claim is that NCCIH will cover any language that the person uses as a primary language. That either they will find a census person who speaks that language, and actually most people don't know, well, the CDC manages the NHIS. It's actually the Census Bureau staff who are collecting the data, especially the in-person data. So just like for the census, they try to find people who speak whatever language might be, and there's census people who speak like they cover hundreds of different language. In a rarer case where it's a language which is very rare in the United States, they'll actually get a family member who's bilingual to translate, and they'll, again, they'll sort of like instantaneous cross-validation to make sure that the translation is understood in the English context. So at least in the terms of NHIS, they do as good a job as you could possibly do to get the surveys done in the appropriate language.
I mean, it is quite remarkable to hear about the dedication to best practices. And of course, the challenges of having, a family member in terms of what is shared. But it sounds like that's only in cases where there really is not a significant number of people
Yeah.
speaking the language.
And this is, parenthetically, I've never actually looked at it, but the NCCIH releases the para data for all the surveys, which the para data basically says what language they're using, who's translating it, where the
Yeah.
translation comes from. So you could, I mean, I don't know how many, you could, if you really wanted to look, see how many people,
Interesting.
how many times family is using it versus a census person.
Yeah, and potential differences. All right, let me ask one last question here, so we have a little bit of a break before our next session. And this question is, can you share any insights into how much the increased use in the past 20 years is due to increased access, more providers, possibly more insurance reimbursement, and how much is due to people seeing articles discussing research into effectiveness or just higher information generally? And how much is due to
Yeah.
cultural changes? This is a difficult question to answer, but do you have?
No, it's not. Actually, I prepared for it. Could I actually share my slides again?
Absolutely.
Okay, I go back to share.
Well, I'm glad we're ending on this one since it's.
Where is it? So, okay, you're hopefully seeing the slides again.
Uh,
Are you seeing it says it's a question? You see
yes,
that?
I'm seeing that, but
Okay,
let's.
okay.
Okay, got
So,
yours. Yeah.
yes. So this is a slide showing the increased offering of yoga as a class in high schools from 1995 to 2014. And you can see in 1995, very few schools were using it. In 2014, 1,000 schools are using it, and it's gone way up. For instance, my daughter took yoga in her, freshman year in high school. She still practices, and she's now, that she's been out of high school for 4 years. So my think is this is a sort of both access and availability. I think kids all over the country are being exposed to different complementary approaches. Meditation is part of yoga, for instance. Some of them pick it up as a lifestyle approach, some of them don't. But certainly in terms of mind body approaches, I think a lot of it is this exposure. In terms of practitioner-based approaches, this is a slide showing the increase in a number of states, in the United States, who have now have regulations for acupuncture. In 1972, there were no states because no one had ever heard of acupuncture. It really wasn't until 74, I think, when that New York Times article came out about the reporter who had
Yes.
a appendectomy. That's when you started seeing individuals getting interested. So you can see by 1982, 10 states, by 1992, 23 states, up to now, where I think it's 47 states currently have some regulations of acupuncture. So you can imagine if a state doesn't regulate acupuncture, there can be no acupuncturists in the state. If there's no acupuncturist, there's no access. So I think this explains a lot of the increase in acupuncture. As the number of states increased, number of acupuncturists increased, and availability increased. So
Yeah. I'm so glad you had these extra two slides. In my own informal observation, teaching first-year medical students 20 years ago, when I would ask at the beginning of a lecture, how many of you have used some type of complementary or integrative, 2 or 3 out of a class of 160, now almost every hand goes up. And then it becomes part of the training of future physicians to understand what patients are interested in. And I think that's part of the exponential growth as well.
what I'm showing here, this goes back to the insurance question. These are data from two different types of data sets. And they both are showing increase of insurance coverage for acupuncture increasing over time. You may not look big increases, but from 2010 to 2000 increase, it was a 20% increase of insurance coverage for acupuncture. As many of you know, Medicare has now approved acupuncture as a reimbursable for back pain. That happened 2 years ago, so we're very interested to see what happens to Medicare coverage after that, because as Medicare reimburses something, you can be sure that commercial insurance companies will reimburse it.
Absolutely, absolutely. Well, I am afraid I'm going to have to inelegantly interrupt our fascinating discussion here so that we can thank you for this portion. We'll take 5 minutes and then come back for another session. But I do want to pause now and thank you, Dr. Nahin, for a just absolutely fascinating presentation. And hopefully people can share some virtual applause. And why don't we go ahead and close out this session, and I'll see you again in a couple of minutes.
Bye.
Thank you so much. Thank you, everybody.